Hello everybody. Full disclaimer, this is my first time talking, so welcome. We're all in this journey together. So I'm presenting the management of a diabetic patient post-surgery. As medicine, we probably wouldn't take Ralph on as a case. He'd primarily belong to surgery, but we would have an involvement with the diabetic side of things. So I just wanted to say a bit about me. I thought referral was super scary. Clearly I was wrong. Now I know what is actually a little bit scary. But I thought it was not for me. I didn't know what I was going to do. I didn't even know if it was going to be something that I could actually achieve. But I did all my rotating through all the different areas, and I fell in love with medicine, and this is where I've kind of stayed. So yeah, if anybody had any questions about that, come find me afterwards. I'll happily talk about that as well. So one of the questions I often get asked is, what is actually internal medicine? And to be honest, I would say we're detectives. We often have patients that are lethargic, pyrexic, they'll be anorexic or hyporexic. We'll have abnormal bloods, whatever that may be. We also have the lovely gastrointestinal signs. And sometimes we just get patients that aren't well and they're just not quite right as our signalment. And we kind of have to work through them, all the clinical signs, all the sides of, usually by ruling out different diagnoses to find our true diagnosis. So procedures that we do, we often do bloods, urine and fecal analysis, diagnostic imaging. Medicine is very imaging heavy. You'll often see us in ultrasound, taking x-rays or being in CT. We also do endoscopy. We actually have 3 scopes with us here at the Ralph. So we have, often we'll be doing something like a upper and lower GI scope, bronchoscopy, rhinoscopy, all of the oscopies, cystoscopies as well. We'll do bone marrow biopsies in our anemic patients. We'll do some joint taps in our patients that potentially have pyrexia of unknown origin. Fine needle aspirates for anything that we may find that is abnormal. We'll do feeding tube placements and management of those throughout. We'll also do nurse clinics, sometimes placing central lines if they're needed. Peripherally inserted central catheters, we usually call them PICC lines. They're like a normal IV, but they're in for longer periods of time. So we as nurses very much will do a lot of different things. We actually can do quite a lot of this diagnostic side of things as well under the Schedule 3, and our medicine team is actually really good, and they are quite keen to get us to do quite a lot as well. So medicine and nursing really can go hand in hand. We have, I've clicked, Sarah, she is one of our rotating nurse interns that just went through medicine. She's absolutely smashing a blood culture. We were getting her involved because it's absolutely something nurses can do. Well, forget about the notes. So diabetes mellitus, what is it? So diabetes is caused by a lack of relative or relative lack of insulin. Insulin regulates our body's glucose. And usually dogs, you'll see them, they'll get type 1 diabetes rather than cats, which they always love to be a little bit different. So causes, we can have an autoimmune destruction of the pancreas, chronic pancreatitis, and usually end-stage chronic pancreatitis as well. Pancreatectomy, pregnancy, though this obviously wouldn't be the case in Ralph, as well as we rarely see it, but it can be seen in Cushing's as well. There are genetic links to Schnauzers, Samoyeds, Australian Terriers and Keeshans, and it tends to be, particularly in dogs, irreversible. So Ralph Ralphison, he's come to us, he's in ICU recovering. Thankfully he is all good. His hypovolemia has been recovered as well. So the considerations of medicine we would be taking is looking at how long has he been diagnosed? Is Ralph Ralphison stable as a diabetic, or is he still uncontrolled? In this situation, he's stable, but we may be tailoring our nursing considerations slightly differently if he was an uncontrolled diabetic. We also need to know how stable is he on his treatment, and more specifically, what type of treatment is he on? Is he on a Q12-hour insulin, or is he on a Q8, which we do sometimes see? We also need to know what is his hydration status. This actually massively affects how we're going to monitor his blood glucose going forwards. So this is something we also need to assess in Ralph. We also need to know what his normal routine is. So ideally with diabetic patients, you want to keep them as stable as possible with regards to their normal plan at home as well as here. We are also looking at how we're going to monitor that blood glucose. Before he's come to us, we've been using a glucometer to measure, but are we going to look at a continuous insulin glucose monitoring system, which I will call a freestyle from going forward, but that is what it's like technically called. So diet-wise, in a diabetic patient, we do feed them slightly different to what we would usually feed to any other patient. So diet really is something that nurses, we can nutritionally get our teeth in, really start talking about. So we want a nutritionally complete and balanced diet. We want free of simple sugars as much as we can. We want a restriction in fat, so any of those low-fat diets are great. We also want them high in fiber. And ideally, this is where we need to know about Ralph's normal routine. We need to coincide the feeds with his insulin. So in this situation, I've put Ralph as a 12-hour feeding, but you really do tailor it to your patients. Also, we just need to imagine that Ralph is actually in a kennel. When I came and brought him a gorgeous bowl of food, my model was actually in anaesthesia at that point. So we're just going to pretend he's in a kennel. So post-operatively, we want to feed a small amount to Ralph. With diabetic patients, I know Robin briefly mentioned it, we want to make sure that they're as sort of stable and as quite quickly getting back to eating their usual routine so that we can monitor their insulin levels. So we also need to think, can we give antiemetics? Have antiemetics already been given? This is why it's really important to kind of monitor those notes as well. Get that handover from anaesthesia. Have they given anything like meropenem? And we also need to assess sorry, it's cut off slightly, but how is Ralph eating? Do we need to think about different things? Has he also been given a sort of dextrose during surgery, or because his glucose has been low during surgery? All of these sort of things we need to consider. And also, do we need to place a feeding tube in Ralph to try and help him get a little bit stable with his eating? The other really important thing with diabetics is their hydration status. So diabetic patients can usually be PUPD. So polyuria is caused by the glucose that is spilling into the urine. It usually causes a shift in that osmotic pressure and kind of pulls that water into the urine. To then balance that, your patient will usually lose more water. So they become polydipsic to compensate, to try and build that water, that hydration back up. So one of the things straight away, I'm thinking as soon as Ralph is conscious and able to not kind of dunk his head into the water, we should be giving that water as soon as possible, just in case he also wants that drinking side of things. The other thing we can do to monitor, especially as nurses, we can get very involved in this, is measure our water intake and the urine output. It often means that we're going outside following them around with a urinary collection pot being like, come on, we need to measure this. But, it's a fun thing that medicine nurses do. We also need to know how can we track the blood glucose. So on recovery, we often need to obtain multiple glucose readings. We usually can do this multiple ways. We also obviously need to think about supplementation if needs be, if he's sort of irregular. If anaesthesia have offered some drugs, we may need to counterpart them with glucose or insulin earlier. And especially monitoring if Ralph's eating, we may be giving some drugs as well. Depending on Ralph's dehydration, it may also affect how we're obtaining those samples. So we can obtain blood glucose using a glucometer, which I feel is usually a regular one that we all deal with, like a little glucometer. Or we can use the Freestyle Libras, which is our continuous glucose interstitial monitoring. So advantages and disadvantages of glucometers. You only need a small amount of blood. It is the smallest ear prick we usually use, don't we? You can have it to species-specific settings, so we can really tailor it to our dogs. It's ready and reliable. You can get a reading within 30 seconds of obtaining the blood. And it can be taught to carers at home. So we can be teaching carers that they can do this. Sometimes, on the disadvantages, they don't want to because they don't want to sort of ear prick the dogs, which is completely fine. So it is a disadvantage. Multiple samples may need to be taken as well, so you may get the patients that are head shy, or they may become head shy because we're continuously ear pricking their head, like going for their head for the ear pricks. And patients long term, like I say, head shy, may be a bit more reactive for a person coming to their head. So we really need to factor these in. I'm just going to talk about continuous interstitial glucose monitoring. This is something we as medicine quite heavily use a lot. So these are little freestyles. It is basically a high frequency glucose measurement, and there is actually the comparison between blood glucose and interstitial glucose is quite similar. So it is something we definitely can use. It is a little probe. I don't know if you can see it on the screen, but it just sits in the interstitial layer, and that magically, I have not understood how it works yet, but magically takes readings of the interstitial glucose. It is super simple to place, and it is super simple to read as well. You often just get your phone, you can have an app, and you just scan it over the dog, and it will give you a reading, and on your phone it will look like this. So you have the current interstitial glucose concentration, which is our numbers. You just have to need to make sure that it is in the right measurement. You have a little arrow, and that will show if the glucose is going up or down as a trend. And then at the very bottom, you start to see a little bit of a graph of where your glucose is going in the last 8 hours. So I hope you all can see it, but these are the different styles of monitorings that we can see without having the patient near us. So we actually just get all of these readings, and this can be over 14 days. So we'll look at this, and there is a grey section between 3.9 and 10. That's where we want our glucose to be. We want it in that grey zone. Now, in the second one, you see the glucose is just starting to peak up and down. This is a patient that is on a little bit unstable at the moment. So we're looking at trying to kind of get that back into the grey zone. And at the bottom, I just thought it was really cool because we don't often see them. But this is a patient that we've got that is on Q8 insulin. And you can actually see where the peaks are happening and then the troughs are happening. And we're trying to get that glucose back in that line. Was a really difficult case that actually we tried different insulin types. We tried different ways, like feeds, changed everything. And actually the only way we could get this patient to be stable was by doing a Q8 insulin. So I thought it was really cool. So some of the advantages and disadvantages of our freestyles. So the advantages, like I said, it can be used in 14 days. And the patients don't need to be at home, in hospital. They can literally go home. We can get a 14-day instead of a 24-48 glucose readings. You usually get a really high client compliance because all they're doing is just putting their phone over their dog however many times a day that they want. There's no need for patient restraint. When placing them, we often have restraint, just somebody holding them. But for measuring, you don't need to have those head shy situations. You can literally just scan the probe. It's really fun. It's waterproof, so it shouldn't affect the dog's sort of general day-to-day life. And we really do get some nice trends going. some of the disadvantages, it does take 60 minutes to work, so we really need to think in our patients, when are we placing this freestyle? Because if we're placing them at the wrong time, we're still going to have to wait 60 minutes for them to work. In those emergency situations, we probably wouldn't be placing a freestyle before the dog's gone to surgery, for example, just because by the time the freestyle's working, the dog's probably already draped up and under something. They can stop working, and they can also be scratched off. So any patients that get really itchy potentially is not your friend with a freestyle. You can have inaccuracies with dehydrated patients because you're monitoring the interstitial glucose. If you've got hypovolemic patients and the blood is sort of, not the blood, the fluid level in the skin is not as normal, you will see a difference in correlation between blood glucose and interstitial glucose. So in these situations, Ralph presenting as a hypovolemic patient, we wouldn't be placing a sensor in him until he is stable or the hypovolemia is corrected, which thankfully Anaesthesia have done for us and ICU, so we don't have to worry about that. It is also one of the things you have to base your client, because you can get clients who are really worried, and so they will continuously scan your patient or their pet at home. So you really have to make sure that the clients aren't going to sort of be bothering the dog too much, but also that like the client aren't going to be worried about every reading. You need to make sure that they're comfortable as well when having a freestyle. So we should have a lovely video, which Elliot will pop up if all works. Here we go. So I just wanted to show how easy it is to place a freestyle. So this is one of my gorgeous patients, Badger. He is really good. So we've just clipped and prepped the skin. We have popped the two sections together, and you'll hear a click. Nothing really changes, but a needle is exposed. So that is the only difference. We will then go through and use glue to secure these in place. We tend to use a needle and syringe just for accuracy when placing the sensor around the area. So we draw up the glue. It also means that we don't get it on our hands. So, you don't get that glue side of things. The prep of the skin, we've just wiped with some ChloraPrep. But you basically just want the skin to be really clean. So Laura, our perfect demonstrator, she's just doing circles or little dots, but you basically go around the edge of the freestyle. You line it up, you press it on the thorax is where we've put this one, and then you basically slowly peel it off. You do want the little white disc to stay. It's super simple. As you can see, Badger has not reacted to it at all. He's really good. But usually the reaction they get is there's a click, and that will usually be what they respond to a little bit more rather than actually the placement. So with Badger, we use the carers have a little reader of their own, so we use that to do the readings. But as you could see, it says wait 60 minutes, which is a little bit of a downside, but it's all good. Thanks, Elliot. So insulin administration, obviously big part in patients that are diabetic. I'd love to say exactly what we would do, but every patient is different, and we really have to base our insulin off what the patient is giving us, basically. So we're monitoring their blood glucose, as well as what they're eating, if they're eating well, if they're not eating well. And we basically work with our clinicians to decide when to give the insulin, how much to give of the insulin. We may be considering a lower dose depending on what's coming up, and what all the vitals the patient is giving us. So with Ralph, we'll be assessing all those different things and potentially giving him a full dose if he's eating as well as he was in the first picture, or we're giving a little bit of that reduced dose, and it really is based off what our glucose is giving us. I just want a couple of little take-home bits. Remember, one size does not fit all with diabetes. So we've got one of our lovely Opfo diabetics, and and an alpaca, and literally diabetes can be seen in both. And we have a freestyle on the alpaca. It is not ours. I borrowed the picture from one of my clinicians. But you really should be monitoring and tailoring our diabetic patients as they are showing us the signs. It shouldn't be put them in a cardboard box and every patient gets Q12 insulin, and we really have to base our nursing off them.